Welcome to the Positive Sobriety Institute Lunch and Learn. I'm Dr. Dan Ingris, the Medical Director and Founder of the Positive Sobriety Institute. This is also an effort between the Positive Sobriety Institute and the Department of Psychiatry at Northwestern Medical Center, specifically the Division of Addiction Psychiatry. So we're very excited to have our two presenters today. This is a topic we're particularly interested in here at Positive Sobriety, and learning about some of the nuances and advancements of this kind of third wave of cognitive behavioral therapy and DBT and that whole realm. Before we get started, I do want to mention that we have a sort of unusual situation where in a few weeks, actually 2 weeks, we have a Dr. James Berry from West Virginia coming here, who's a true expert at working with MAT, medication-assisted therapy, and really weaving in a comprehensive behavioral program along with it. So we're excited about that. It just turned out with his schedule that it had to be a little bit earlier in the month than we normally do it. So please try and attend that as well. So let me introduce our two speakers today. Dr. Danielle Doucette is a licensed clinical psychologist and certified eating disorder specialist and serves as the clinical director of eating disorder treatment at Midwest Counseling and Diagnostics in Chicago, Illinois. She has had the privilege to present at numerous professional conferences throughout the United States on topics related to eating disorders, self-injury, and acceptance and commitment therapy. Dr. Doucette is a member of the American Psychological Association and the International Association of Eating Disorder Professionals. In 2018, she completed a 10-day intensive training with a treatment developer of radically open dialectical behavioral therapy, our topic today. She stays up to date on research related to clinical psychology and uses ACT, exposure and response prevention for OCD, and RO-DBT in her clinical work. Rose, here I said I would remember it. Metivier is a licensed clinical professional counselor and the intake director at Midwest Counseling and Diagnostics in Chicago. She has extensive experience working with adolescents and adults, providing individual and group therapy related to a wide range of issues, including addiction, eating disorder, trauma, and self-injury. She received an undergraduate degree in psychology and Italian from the University of Colorado and graduated with honors from the Illinois State University with a master's in clinical and counseling psychology. She is board certified with the National Board of Certified Counselors and certified in DBT and EMDR treatments. Completed Thomas Lynch's 2-day intensive on RO-DBT, again our topic today, in 2015. She works primarily with DBT and other mindfulness-based approaches, placing a priority on collaboration, transparency, and humor to promote insight and change in a safe, strengths-focused environment. In addition to providing individual therapy, Dr. Doucette and Rose co-facilitates a weekly RO-DBT skills training class and a standard DBT class at Midwest Counseling and Diagnostics. And we'll start off with Danielle.
Hi, everyone. Hi. All right, let's get started. We're going to talk about radically open DBT today. And I guess I just wanted to start off by talking about the fact that before Rose and I started working in private practice, we worked in higher levels of care, residential treatment, partial hospitalization programs, and we treated chronic and severe depression, eating disorders, self-injury, substance abuse, sometimes a combination of all of those things. And when we think back to that work and the work that we do and reflect on the work that we do now, we kind of can see two different groups of people. And I like to think about people coming into our group therapy, that when we were doing a lot of group therapy and higher levels of care, oftentimes we were providing interventions that really helped with behavioral and impulse control strategies. Let me tell you about the two groups that we can kind of recognize, that we see coming into our office or into those kinds of groups and higher levels of care. So the first group of people, and think about for yourselves if you can kind of recognize some of these traits in some of the people that you guys work with. The first group of people would come into group in the morning during their check-in, and we knew exactly what they were feeling. We knew if they were angry, if they were depressed, if they were really excited. We knew it because they would just openly report it, and it was just obvious. We knew what they were feeling. If they maybe had self-injured or abused substances before coming into programming, again, we would know about it. It would be either obvious, we would see it, or again, they would just openly report it. If their family members came into treatment for some sessions, they were never surprised that their loved ones were struggling to the extent that they were struggling. It was quite obvious. So that's the one group. The second group of individuals we can say came into group or into our sessions, an individual, and we really struggled to know exactly how they were feeling. They came in and their emotions were very constrained, maybe very measured and constricted at times. So it's harder to see exactly what was going on inside. Maybe they would just kind of smile as if everything was okay as well. They maybe did all the homework and did what they needed to do, came to group on time. If they had self-injured, however, we didn't know about it. Self-injury is a well-kept secret in this population. If their family members came into treatment, they were oftentimes shocked or surprised to learn it to the extent that the clients were struggling. So we have these two different groups of people in our groups, and we would do a lot of behavioral and self-control strategies with them. So Tom Lynch is the treatment developer for Radically Open DBT. And before developing Radically Open DBT, what he did was work on treating he was trying to treat very chronically depressed adults who had multiple episodes of depression throughout the course of their life. And what him and his research team was trying to do, they were trying to adapt DBT for this chronically depressed population. And what they soon discovered was that the traits and the characteristics of these very chronic folks did not match the characteristics and the traits that DBT was targeting. Poor impulse control, right? Emotional dysregulation. They were struggling with something a little different. So here's what we know. Some people do not get better with treatment, and oftentimes it's because there's a personality disorder or chronic mental health conditions. 40 to 60% of people with depressive disorders do meet criteria for a personality disorder, and existing treatments weren't always effective. Most evidence-based therapies that we have today are tested on non-chronic and non-comorbid populations. RO-DBT is tested on chronic and comorbid populations. So that is one difference to keep in mind. In their randomized controlled clinical trials, they have chronically and severely depressed adults. Okay, so let's take a look at the relationship between self-control and well-being. Recent ideas think about this in a very linear way, right? So the more self-control we have, the more control we have over our urges, our impulses, our appetites, the better, right? Does this make sense? This is kind of what we think about. You might have heard people in your life or people around you ever say to someone you know, or just kind of hear something like, you have so much control. That is, I just wish I had so much more control, or something to that effect, right? Like, control is something that's valued in society. If we don't have a lot of control, we are then what we call under-controlled, and we know people who are under-controlled kind of engage in behaviors related to substance abuse or criminal activity. So we know, well, existing ideas say that self-control is this linear process. But really, that is actually not the case. A lot of robust data, when we really take a look at the research, we find that it looks more like this, that the relationship between self-control and well-being is not linear. So it looks like this. We have a level of optimal control that's really healthy for us. And if we can have too little, we also can have too much control. So if we have too little, we're called under control. These are highly disinhibited folks, right? Really disinhibited, emotionally dysregulated folks. We're trying to get them to move here. We're going to be teaching them behavioral and impulse control strategies, right? Which comes from a lot of our behavioral interventions. If you have too much, you're called over-controlled. Highly, highly constrained and emotionally inhibited folks, like that second group I told you about early on. We need to get them over here. How are we going to do that? We're not going to do that the same way that we're treating the under-controlleds. They have a sufficient amount of control. What does this group need? Believe it or not, what this group needs is to learn how to chill out and relax. So, what we know, and researchers from around the world have pretty much come to a consensus, that by the age of around 4 or 5 years old, we start to see one of two coping styles emerge in children. Okay, so that first one is the under-controlled, right? This is what's targeted in standard DBT. Children who are under-controlled are oftentimes described as very excitable and loud, and you know exactly what they're feeling in the moment. If they see a cookie, they're just going to grab one and not think about any of the consequences. As adults, they just might not show up to their appointments with you, and they don't think about the consequences, right? That's under-controlled. Over-controlled coping is the second. So children who are over-controlled are oftentimes described as very shy and timid, right? They don't wear their emotions on their sleeve. They are really good at delaying gratification in order to especially accomplish a long-term goal. So we see that in problem in anorexia, for example. So they're able to delay gratification. They also set really high standards for themselves, and they're really good at meeting those standards. As adults, this group, of over-control, excessive over-control, they oftentimes feel very socially excluded and isolated. Sometimes they struggle with also how to join socially and connect with others. So that's kind of something to keep in mind. So we have two different problems. Think about that bell curve. Two different problems at two different ends of the spectrum, under control and over control. Two different problems, we need different interventions therapeutically, right? So over control is a problem of emotional loneliness. Now that is secondary to low openness and poor social signaling. And that is what RO-DBT targets. Under control is not a problem of those things. It's a different problem. It's of emotional dysregulation, and that is secondary. This probably is not a surprise to any of you. Poor distress tolerance, right? And poor impulse control. We have really great interventions to target these problems. So, some different ways of thinking, and a lot of research. Over 20 years, RO-DBT is developed. So it is a new treatment. It is a trans-diagnostic treatment. So trans-diagnostic treatments, really cool. They cross diagnoses. So they're not a specific treatment for a specific psychological disorder or psychological problem. They're trans-diagnostic, which means they consider biotemperament, right? So biotemperament is the biological basis for emotion, and it influences two things. One, how we perceive the world, and two, how we regulate emotions. And that's what we kind of target in these trans-diagnostic treatments, such as RO-DBT. So this is I'm going to talk about this randomized controlled clinical trial later. I know, very exciting, but I just really wanted to pull this from one of Tom Lynch's earlier, his second randomized controlled clinical trial, where he looked at a sample of mid to older adults who were depressed. They also had comorbid personality disorder, and they were chronically depressed. A lot of depressed episodes throughout the course of their life, mid to older adults, I think 55 and older. And what he did was he looked at the distribution of personality disorders in that sample. And what he found was that 73% actually met criteria for what we would consider over-controlled personality disorders, namely obsessive-compulsive personality disorder, avoidant personality disorder, and paranoid personality disorder. These were the most common in this chronically depressed population. If you can't see it, borderline personality disorder was 10%. Something else that we also know is that over-controlled personality disorders tend to not remit and recede with age, like borderline personality disorder does. So we see a lot of chronicity with this population. So these are actually traits and characteristics that you would find in the DSM under those over-controlled personality disorders. I want you to take a look at this. Again, think about maybe clients you might work with. So we have really high on social inhibition, so closed off socially, right? Distrusting of others or questioning loyalty, or doubting trust in relationships, holding grudges. These are things that's actually targeted in RO-DBT, or these traits from these OC personality disorders. So Rose is going to talk a little bit more about this over-controlled life and what that looks like. We know that it's chronic. We know that it can be really severe. Let's take a little bit more of a look at this emotional loneliness and what diagnoses it crosses. So.
All right. I had one wired mic, so I get the Madonna microphone. So don't tempt me. So we look at that OC life, and I'll have you, so I can still gesticulate to all of you. So not every single time, but in general, we can look at some disorders through the lens of the under-controlled traits and some disorders through the lens of over-controlled traits. And what we see pretty clearly, as Danielle was alluding to, is that a lot of these disorders over here are very externalizing. The behaviors that are problematic with these disorders are known very quickly. They sort of very destructive, harmful. They impact relationships. These are the squeaky wheels that get the grease. These are the ones that become very apparent very quickly. The over-controlled traits and disorders, not so much. And in fact, some of these traits, like routines, being highly detailed focused, being very rigid, actually might be reinforced in personal and professional areas of their life. So the things that are going on in the over-controlled sort of presentations are actually pretty private and pretty secret. So for this reason, OC disorders and tendencies don't really get recognized as a problem as quickly as under-controlled might. So we look at the OC life and we see that it's an incredibly lonely life. So that doesn't mean that there's a lack of social contact. It could be somebody who's the CEO of a company. But there's a lack of social connectedness and intimacy. And that connectedness and intimacy forms the foundation of our relationships. And that's of the utmost importance in radically open DBT. So we think about the poor social signaling, the low openness, masking emotions, and what that does is it really sets that person apart from the tribe. And maybe sometimes it's not just their perception, they really are, because of those tendencies, excluded from the tribe. That loneliness, that isolation actually worsens anxiety and depression. So in the OC life, nothing is as it seems. It's controlled, it's rigid, it's lonely, and it's also shrouded in mystery to people who are kind of on the outside. So it's not that things that we would think of as more under-controlled behaviors like self-harm, addiction, binging, purging, it's not that those aren't happening in OC presentations, but they're very private. They're more likely to be deliberate. They're more likely to be planned. There's some aspect of ritual or routine to it. It's a very private harm. They're doing pretty much everything they can to make sure that people don't know the extent of their pain and of their struggle. When we think about somebody who's seeing mistakes everywhere, working harder to prevent future problems, they're expert at not appearing deviant to the outside. So as you think about clients that might sort of meet some of these descriptions of over-controlled tendencies and traits, you also know that these are the clients that you can't really take at their word, that what they say isn't necessarily what they mean, that they'll agree to something and have zero intention of following through on it, that they are just ready to appease and get the conversation over with and be on their way. And you really can't read them. They might just stop therapy abruptly and you have no idea. It seemed to be going so swimmingly. And so in this group, compliance and agreement doesn't actually mean that there's engagement or buy-in. And so this is also another reason why we really kind of need a different approach with these specific presentations. So kind of looking at these can see what they might say, what they actually mean, what others hear. And this is also happening in their personal relationships, so we can also understand why their relationships aren't necessarily intimate or connected, because they're also not presenting a very genuine or authentic version of themselves to those people either. So if we think of the three markers of psychological health, think of somebody who is that you know is psychologically healthy. Maybe you after a 2-week vacation in Hawaii. We're going to tend to be receptive and open in a healthy state. We're open to learning. We're willing to accept feedback in service of growth, in service of improving something. We're open to new experiences. We're also going to have the capacity to flexibly respond, to look at a situation and say, well, this is how I normally would do things, but given the context of this situation, I'm going to switch it up a little bit. So if you think about if you've ever gone to England and rented a car and had to drive on the wrong side of the road, you have to be able to flexibly respond. And then we also have intimacy and connection. People who we consider psychologically healthy, you after a 2-week vacation in Hawaii probably have good relationships, meaningful, valued relationships with people, intimacy and connectedness. And when we look at the OC presentation and OC deficits, we actually kind of see the opposite. And so we see that there's a lack of receptivity and openness. They do everything in their power to avoid having to get corrected or hear feedback. And I have a person with an over-controlled presentation talking about a review coming up at work. It's like the worst thing in the world that they're about to hear feedback about something. They spend a lot of time making sure that their world is predictable, making it almost impossible for them to learn and grow and be exposed to new information and experiences. There's a lack of flexible responding, there's rigidity, there's routine, and that also makes it difficult and almost impossible for them to effectively navigate the curveballs that life is inevitably going to throw us. There's a lack of emotional expression and awareness. They're so inside themselves and in such a state of threat all the time that they're not really that attuned to the emotional signaling of other people, and they're also not really capable of appropriately signaling to other people what their emotions are. They might have sort of a flat or neutral face or sort of angry face. And a lack of social connectedness and intimacy. They intentionally are keeping people at arm's length. There's not a whole lot of intimacy and connectedness, leading to this sort of fundamental issue of emotional loneliness. So when we think about sort of the goals of RO, we think about flexibility. So let's think about flexibility. So right now, I want you all to look at your hands, and maybe there's a ring or a bracelet or a watch that you're willing to engage in this with. And I want you to just take a quick moment. I want you to move that ring, watch, or bracelet to the other hand. Just real quick. If you don't have anything, then just try to write with it, put your pen in your non-dominant hand or something along those lines. So just do that. I just want you to notice what that feels like. Does it feel weird? Is it uncomfortable? Is there a desire to put it back? Are you completely open to it and it doesn't make a difference? Just notice what your reaction to that is. And I'm going to move on. And I want you to, put it back whenever you're ready to put it back. I just want you to notice and be aware when you decide to put it back, whether it's right now, 5 minutes from now, or 5 hours from now. Just notice that point where you make the decision to put it back, that point where there might be some relief that there's something is familiar again, or back where it should be, or where it normally is. Right. So this is just sort of demonstrating our response to unfamiliar things and how hard it might be to be flexible with something as small as an accessory. And we're asking our clients to do this and a lot more. So increasing flexibility and openness is not a small task. We seek to increase flexibility, openness, emotional expression, the things that are going to allow us to connect, to learn, to grow. We're going to try to decrease the behavioral over-control, the aloofness, the emotional loneliness, the things that are going to keep us isolated and stagnant, in an effort to really focus on social connectedness. Social connectedness is fundamental, and social connectedness and how we sort of signal to each other how connected we are is one of the primary mechanisms of change in RO-DBT. So I'm going to hand it off to Danielle to talk a little bit more about that.
Okay. It's making sense so far when you think about some clients, some maybe struggling with really chronic problems, right, or not responding to maybe some interventions. Hope this is making sense. So, I want you to imagine a person being born with a brain that is sensitive to negative things and less sensitive to positive things. If that person walks into a rose garden, they're going to notice the thorns rather than the roses. This is this is biotemperament. This is what they are hardwired for. So let's take a little bit more of a look at what the hardwiring looks like in the over-control. I'm going to give you some examples. First, we have low reward sensitivities. These over-controls are not very excitable at all, right? The other night, I'm watching a show with my husband, and it was a show, and there was a magician on, and he did a magic trick. I'm very low, I'm on the lower end of low reward sensitivity. So when when the magic trick was over, my husband was like, oh, did you see that? That was so cool. How did he do that? That was so amazing. And I'm like sitting there, I'm like, oh, that was cool. And I'm like, that's a low reward sensitivity. It's innate. It's just kind of part of who we are, right? But we work on that in RO-DBT. High focus on details. So over-controlled will kind of miss out on the big picture and focus on details. They might notice a book misaligned in your office. Now you might think, like, why does this matter? It matters for two reasons. One, does it even matter if the book is misaligned or not? And two, how does that impact relationships? And sometimes it does, because when they're so high detail focused, they focus on that over the relationship. And that becomes the priority in the moment. I need to fix that. I need to do something. And then they miss out on the big picture. Now, being highly detail focused, by the way, is extremely reinforcing in this world. And oftentimes, OCs will be drawn to careers in this area. Higher degree, advanced degrees, physics, medical profession, things like that, that really or lawyer, things that require high detail focus, right? So again, this could be something that's very highly reinforced, and we have to figure out where the drawbacks are and how it impacts relationships. High threat sensitivity. Again, they're going to see the thorns rather than the roses. And by the way, pairing that with high inhibitory control, you're not going to know about it. You're really not going to know how much they're seeing the thorns rather than the roses, because they can control that mostly in the moment until there's what we call emotional leakage. And then you will see how much it's dysregulating to them. So let's imagine that person with that brain that sees the thorns instead of the roses growing up in an environment or a culture that says, listen, you need to be prepared and you can't make any mistakes. And a B is not good enough. You need to get an A. You need to be in control of your emotions, not show vulnerability, and cannot be weak. So growing up in this kind of environment, with that biotemperament, how do you think this person learns how to cope? Kind of everything we've been talking about so far today. They learn how to cope by masking their feelings. Now, that's a problem, because people like people who openly and freely express their emotions, the positive and the negative ones, right? People who express their emotions openly are perceived as a lot more genuine and authentic. So if you're masking your emotions, you're coming across very aloof and distant, right? They'll also avoid taking any risks, too. That's another coping mechanism. So that's the biosocial model for disorders of over-control. Rose.
I'm back. All right. So we think about the tribe, and we also take into account not only the biotemperament, not only the culture, but also just our evolution, how we're all of us designed. All 7 billion people on this planet share the same sort of source code. And how did we, pretty thin-skinned, no claws, no teeth, not particularly speedy, how did we come out on top? What was the secret to our evolutionary success? And really because a lot of other mammals know the secret too, but we relied on the power of numbers. The tribe is fundamentally one of the most important things to our survival. The people who are sort of shunned from the tribe or decide to go it alone are off in the forest by themselves. They're not going to last very long. But when we were in a tribe, we were able to share resources, raise each other's children, protect, plan, collaborate, build, to the point that we're giving presentations on it now. So that importance of the tribe is really dependent on our ability to create long-lasting bonds. And our ability to create long-lasting bonds is dependent on our ability to communicate to each other and also signal to each other very quickly whether or not something is good or bad or right or wrong, safe or unsafe, whether I'm closed to you or open to you. We're constantly signaling these things non-verbally in ways that we're totally not aware of. We'll talk a little bit more about that in the next section. So we need relationships. We need the tribe. We're constantly signaling whether we like it or not. So that is one of the most fundamental things to keep in mind, that that's how we're all designed. So then another sort of aspect of how we're all designed is with a system that allows us to constantly and unconsciously scan our world around us for threat, and that we can respond very, very quickly. And we can move sort of through these systems in different ways. So if we talk about the neuroregulatory system and how we are unconsciously sort of either in the safety system, which if you can see adorable fuzzy puppies. I met Lars out here just before the presentation. I was immediately moved into my safety system, and I wanted to pet him and cuddle him and love him. He's precious. So the safety system is where we're calm, we're resting, we're digesting, we're connecting, we're learning, we're open. The novelty system is where we sort of heard a rustling in the bushes, and we're not excited, really. We're not totally in an excitatory stage, but we're not really calm either. We're attentive, we're alert, we're trying to figure out, do I need to run, or is this exciting? What's going on? And then depending on what actually happened, we're going to quickly move into maybe a reward state. Maybe the rustling in the bushes was, if we're old enough to remember Ed McMahon with a $10 million check, and I'm super excited, and I'm in my reward state. If you've ever seen the movie Elf, Buddy the Elf is constantly in a reward state. Santa! There's the threat state, maybe that it's not Ed McMahon, it's a lion. We immediately go into threat, fight, flight. This is where we're ready to fight for our lives. This is survival mode. If you've ever seen Seinfeld, there's an episode where George Costanza's running from a fire in an apartment. He was like barreling over old ladies and children. He was in a threat state. And then there's the state that's overwhelmed, when we have tried to sort of attain the goal but couldn't get there, or we tried to address the threat but could do nothing about it, we shut down. This is our conserve energy system. This is our system that wants to play dead till the threat is gone. This is the system that allows us to dissociate from the pain of the lion biting down on our neck. This is the system that just completely goes offline. We are always in one of these 5 systems, whether you know it or not. And it's your body responding, not your brain. And so understanding, too, that our ability to connect with people totally depends on what system we're in, because Buddy the Elf and George Costanza are not aware of other people. They're not aware of their social signaling. They don't care about relationships. They're not open to learning. Dead Bunny, playing dead, isn't open to learning, isn't caring about relationships. And even novelty, if you think about when you're lost and you need to, in the car, turn down the radio because you're lost and you need to think. And if there's people talking in the back seat, what do? What? That's not super connecting. And we might not be as aware of social signaling. So we really need, for the sake of socially signaling, openness, connecting, learning, we need to be in our safety system. So we talk about social signaling. I'm going to hand it over to Danielle.
So RO-DBT, we actually prioritize social signaling. It is the primary mechanism of change, and is one of the first treatments to say social signaling is the primary mechanism of change in this therapy. Because of that, the RO-DBT therapist, both in our individual and in the class, is constantly attending to nonverbals, small little micro expressions, right? Kind of notice any guilt or shame or whatever it might be, changes in eye gazes or voice tones or body postures or even length of responses. We're constantly attending to those behaviors that might signal something that signals aloofness and distance rather than connection, because we're going to have to point that out. The other thing we have to do as RO-DBT therapists is think about our facial expressions and how we are showing up. So I want you to think about for a moment, when you're with a client or you're with somebody who you care about who tells you something that's concerning or maybe that worries you, think about what your face does. And see if you could do that for a second. Maybe look to the person next to you. What do you do? Okay, this is perfect. You're doing exactly what we do, right? Which is this. We kind of furrow our eyebrows down a little bit, right? Now, imagine this with someone who's highly sensitive to threat. This. So remember that biotemperament, think that high threat sensitivity, right? That high detail focus. This, highly sensitive to threat, right? That could be threatening to some of the RO-DBT clients, where with someone else who's not over control, this might really spark some, oh, this person gets what I'm saying and is empathizing with what I'm talking about and is really concerned. But with an over control client, this could be really this threat, right? So what does your face do? We're going to talk about that because we talk about this with our clients all the time. We're like, what is your face doing right now? So we're going to do a little exercise together. What is a universal signal for I like you? Or we use the word tribe. We talk about tribe all the time in RO, or that we want you in our tribe, or that you're in the tribe. What's the universal signal for that? Okay, we're going to eyebrows. So what we're going to do, well, eyebrows raised. What we're going to do is I'm going to ask you to pair off with someone next to you. This will be really quick. So pair off with someone next to you, or just kind of someone behind you or in front of you, whatever you might need. And Rose, should we have them stand up? Stand up. Get the blood moving. Get the blood moving. So what we're going to ask you to do in this space that you have with your partner is to imagine that you are in the airport and you run into your long lost friend. Go, 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 greet your long lost friend like you would in an airport. Go. Haven't seen you in years. Okay. So now what I'm going to ask you to do is you're in the airport, you run into your long lost friend, and you're going to greet them, but I want you to keep your eyebrows down or neutral. Go. Keep those eyebrows down. Keep those eyebrows down. Okay, you guys can have a seat. Thank you. Thank you for participating in that. Okay. Guys, what's really cool is that we know that our eyebrows influence so much. They influence our tone of voice, our body postures, our action urges to move in a certain way. Did you guys experience that a little bit? They show how we feel, and they say, hi, I want you in my tribe, I like you, right? They really do. So this is one intervention we actually do with our OC clients in class, right? To kind of teach them to bring their eyebrows up and what it feels like to keep them down or up, or kind of how that impacts other people around you. Really important stuff. We pay attention a lot to eyebrows, so much so that Rose drew eyebrows on her dog Dumpster. But eyebrows are so important. The placement, and we talk about them a lot. We have so many muscles in our face, and we have to teach our OC clients to use them. So, as we're teaching this stuff to our clients, we want them to know that what's most important is not what you say, but how you say whatever it is you're communicating, right? And OCs will bring certain moods and behaviors into situations, social situations, that make those social situations worse. So, in order to demonstrate this, we tell a little story. This actually happens in week 3 of the class. Lesson 3, we start off with this story, and we read it, but I don't have it in front of me, so I'm going to give you a little summary of this story. So it's a story of this man, and he's talking to his friend, and he says, nobody likes me. And his friend says, that's not true. People like you. I want you to go to the town village and sit in the square next week, and you will see that people like you. So he says, okay, I will do that. The next week, he sees his friend, and he says, how did it go? Did you go to the town square? He said, oh, I went to the square. I brought my hunting dogs with me. I brought my shield on my back, my sword in my belt, and I sat on the bench. And guess what happened? The moms ran with their children, and the fathers looked at me with contempt, and you think people like me? So basically, that's the story. And what are we trying to kind of get at with that story? We're trying to help our clients understand, what are your shields and swords that you bring into social situations? And sometimes we hear things like maybe a crossed arm or just like a rigid posture. right? Or sitting on the edge of their seat like something bad is going to happen. Forced smiles, and we are really good, humans are really good at detecting an inauthentic smile, right? Kind of looks like this. Yeah. Accusing others of nefarious motives. They don't really like me, or they don't have my best interest in mind. Again, remember back earlier on, doubting the loyalty or struggling with trusting others, being overly apologetic or not apologetic at all. Again, which swords and shields are you bringing into social situations that are making them worse? How can we kind of bring some awareness to that? So, like Rose says, we have that neuroregulatory model of emotions that we teach the clients, and we're constantly teaching them to activate social safety, because when we're in safety, that's when our action urge tendency is to socialize, right? Not be aloof and distant, or not be in kind of fight or flight mode in that state of threat. So we have to constantly teach the clients skills and practice them over and over and over again related to activating their social safety. Okay, I did this before our talk here today. So Rose is going to talk about one of the first skills of many that we teach around activating social safety in RO-DBT class. It's called the Big 3+1.
Every time I take this microphone, I feel like I'm going to sing. It's going to be great. So we need to be in our social safety system in order to connect, in order to learn. We can't do it in any of the other systems, and someone with over-controlled tendencies is pretty much constantly in a state of threat. So we need to move into a state of safety. It's not a conscious process. You cannot think your way out of your threat system. You have to body your way out of a threat system. It's not a process that you can sort of make a choice. We really need to engage our body. So if we think about, and specifically engaging that parasympathetic nervous system that's in charge of the calming and soothing, we engage in the Big 3+1, which is essentially these three things that we're doing with our body to sort of calm down. So the first one, big deep breath. So everybody, right? We actually do what we call a closed mouth cooperative smile. It's not a fake smile, but just a smile. And it's closed mouth, so you're engaging these muscles, the eye muscles a little bit. Just a cooperative smile. Wag those eyebrows. It doesn't mean keep them up there like this. It just, a little wag, just kind of resetting and kind of having those go up. So you take a big breath, wag the eyebrows, cooperative smile, and actually the +1 is lean back. Lean back. Lean back. I'm pointing you out. So now you're in threat. No, lean back. So that's just a quick physiological way to just kind of engage the social safety system. I don't know if you feel any differently. Okay, so now that we're all in safety and open to learning and connecting, Danielle's going to talk about the evidence for RO-DBT.
Actually, before evidence, we're going to talk a little bit more. We can't talk about radically open DBT without talking about what radical openness means, right? So before we even get into openness, let's talk about being closed. What do you do when presented with information that's disconfirming some deeply held beliefs maybe that you have? Remember those 3 markers of psychological health and well-being that Rose talked about? The first one is openness and receptivity, right? So when you're closed, and what do you do? So you're in a meeting, and someone kind of says something, and in your mind you disagree, and you're like, they don't know what they're talking about. So do you dismiss the person? Do you shut down and just completely numb out? Do you decide that you're going to ignore them and never talk to them again? Do you just change the topic? Do you pretend to agree when you really don't? OCs will do that, right? What do you do when presented with information that's disconfirming or that just goes against a viewpoint of your own? And we all do this. Can we recognize when we're being closed? If we can't, we're not going to be able to practice radical openness. So radical openness is this idea that we come to every moment with our own perceptual and regulatory biases, right? And those biases that we come to every moment with impact our ability to be open and to learn, right? So we kind of think of this quote and we kind of carry this with we ask our clients to kind of carry with them this quote. We don't see things as they are, we see things as we are, based on our experiences, our perceptions. So what is radical openness? Hang in with me for a second. It is developing a passion for going opposite to where you are. Now, who knows what that means? It is actively seeking what you want to avoid. You want to avoid it, we want you to seek it. Going to be open. That involves trying new things, self-exploration, challenging your perceptions. It's not about letting go of fighting reality, because what is that? Radical acceptance. So radical openness is not the opposite of radical acceptance, by the way. It's something different. Radical acceptance, letting go of fighting reality, comes from the spiritual tradition of Zen Buddhism, right? Which is influenced in standard DBT, right? Where we kind of accept the situation without trying to change it, unless we can. Radical openness comes from a different spiritual tradition. It comes from Malamadi Sufism, which goes back to the 9th century, actually. And the Malamadis, what they didn't want to accept in the moment or accept kind of fighting reality, that they needed to kind of drop that. What they wanted to do is cultivate healthy self-doubt. They wanted to find fault in themselves. To do that, you have to be open. If you're closed, you're not going to learn. And you're doing this in order to learn. So the way that we do this, and we practice with our clients, and as a practitioner of RO, we practice what we call self-inquiry. It's kind of like a mindfulness practice in RO, where we cultivate the willingness to be wrong and to doubt ourselves in a healthy way, find fault in ourselves. So let me tell you about the self-inquiry practice. When we practice self-inquiry with our clients or with ourselves, we do it for less than 5 minutes, because we are asking people to turn towards what they don't want to turn towards their discomfort, right, without regulating. So turn towards your discomfort and don't take a deep breath, and don't self-soothe, and don't validate yourself, because you're not going to learn if you're comfortable. We have to find a way to bring you to what we call in RO your edge. Your edge is the place of learning, and it's the place of discomfort. We want you to learn something new. In order to do that, we practice self-inquiry, and we do that by asking questions. Rose is going to talk about those questions.
So I want you to think about a time in the last couple of weeks, some recent, where you felt challenged and closed, where somebody sort of upset you, maybe you felt like you were digging your heels in, you felt defensive, felt like you were sort of dismissing this other person, closed, challenged, that kind of thing. Everybody have that incident in mind? You kind of feel in your body what you felt in that moment? I want you to go ahead and ask yourself these questions in relation to that incident. And just notice, don't try to regulate, don't try to seek answers, don't try to validate yourself. Just be open to these questions. Does my bodily tension mean I'm not fully open? Is there something here to learn? Do I find myself wanting to automatically explain, defend, or discount the other person's feedback? Is that a sign I might not be truly open? Is the feedback I'm being given something I've heard from others before? If so, what might that mean? Is it possible there's something to learn from this feedback? What might my resistance be trying to tell me? Is there something to learn here? You can see sort of repeated over and over, that bottom line with self-inquiry is, what is there for me to learn? Is there something for me to learn? As we turn toward the discomfort, toward that edge, and are open to that. So we notice the discomfort, the edge, we ask the questions, and we flexibly respond. We choose then, given the context of a situation, how can I be most effective? What's necessary? What's needed here according to my values or the needs of other people, but also according to what's going to help me stay a part of the tribe and connected and supported. And so those are some of the skills and some of the concepts that we talk about. So in terms of another sort of quick word on flexibility, we talk about fixed mind, fatalistic mind, and sort of in the middle there, a flexible mind. As we talk about a fixed mind, is a closed state of mind, and it's really digging your heels in. There's no reason for me to be open to anything else because I already know I'm right. So this is the captain of the Titanic that says, icebergs be damned, full speed. Fatalistic mind, sort of throwing the hands up, what's the point? Who cares? Nothing matters. This is the captain of the Titanic that sees the icebergs and runs into the cabin, locks the door, and doesn't do anything to try to steer the ship or help the passengers. But a flexible mind is a captain who doesn't turn around at the first sign of danger, but also responds accordingly and keeps an eye out for the threat and is able to sort of maneuver. And so fixed and fatalistic mindsets are closed states of mind. And again, when we're in that closed state of mind, we're in a threat state, we're not open to learning, and we're not really open to connection. So relationships are negatively impacted, we're disputing feedback, enter the self-inquiry. So when we start recognizing that we're in a closed state, we use self-inquiry. What is it that there might be to learn from this? What might my resistance be saying? We also in RO-DBT then have sort of the structure of it is a combination of individual and group modes. So we have a skills training class, that's right, it's very specific, it's not a group, it's called a class. A skills training class that's 30 sessions where we teach some of these skills, the big 3+1, we teach about the eyebrows, teach about social connectedness, radical openness, self-inquiry, and even sort of dealing with difficult feelings like bitterness and envy, which might sort of happen when you feel isolated from the tribe. We then have pretty structured individual RO sessions where we also use a diary card, and that diary card really targets specific behavioral themes. Over here, the inhibited disingenuous emotional expression, hyper-detail focus, rigid rule-governed behavior, aloof distant style of relating, high social comparison, envy, bitterness. So those things are really explicitly targeted and individual. And also knowing that the therapist is constantly keeping in mind their own social signaling. Eyebrows up all the time. I've never been so aware of my eyebrows in my whole life. What's my posture? What might I be signaling to this client that's in a high state of threat? How can I move myself to safety? And sort of modeling for them the appropriate signaling and being able to kind of even be irreverent with them to kind of kid around, use humor even to sort of like open up that safety and create that opportunity for connection. So now, Danielle's
We have a few more minutes, but I will kind of talk about this a little bit more quickly. The RO is evidence-based. Hundreds of patients have received RO-DBT throughout the world. Most new treatments have much less supporting evidence. It might be because maybe the treatment developer was open rather than closed, and we'll talk about that actually in a minute. But 5 published trials, 2 completed randomized controlled clinical trials, the gold standard for empirically supported treatment, and an additional one underway. I will just say that 2 randomized controlled clinical trials that were done, essentially what they found was that in the first trial, 71% of the RO-DBT patients were in remission. Same happened in the second trial. Now, after the second trial, the story goes, Tom Lynch could have published the treatment manual, and he didn't. He continued to do research. He felt like we needed to know more about our OC clients, right? So currently, a 3rd RCT is underway. It's a huge project that they're looking at right now. So there's also been non-randomized controlled studies looking at, well, what happens if clients just attend the skills group, the skills class, and not individual, right? And they did show that there's still some effectiveness just by skills training alone, even if you don't have an individual RO therapist, which is kind of cool because there's not a lot of RO individual therapists. And then quick glance at just ongoing research. In eating disorders, we see some research, a group of researchers looking at RO-DBT in forensic setting of over-controlled violent offenders. They're looking at use OC and RO-DBT. There's a group doing some research on shy, timid, socially excluded children. There's also a social signaling lab underway on the West Coast, and there's a group in Ohio looking at soldiers and veterans who are more over-controlled. And also there's in New Jersey, a group of researchers looking at perfectionistic, hyperachievement focused, think the maladaptive perfectionism in over-controlled university students. So kind of what's coming through up the pipeline a little bit. That is what we have for you because we wanted to save some time for questions if you had any, and we just want you to know that you can connect with us and email us, and we want you to do that. So that's it. That's all we have. Thank you for being here. So, yes.
2 questions. One is, do you do any personality inventories or objective kind of testing?
There are assessments to assess for OC, over-controlled, and when clients come to me for an assessment, I give them some assessments that the research team, Tom Lynch and his colleagues, developed specifically to make sure that people actually are over-controlled. If people come to me and they don't lean more over-controlled, they do not go into the group. I recommend standard DBT because then they're more under-controlled. So that's what they need, and that happens too. People will refer and they'll say, I think they need RO, and then they come out and say, actually they are more under-controlled. They benefit more from standard DBT.
Right, and And I ask that in part because working with personality for so long, I recognize that it's often not this, not that.
Mm-hmm.
You know, it's complex adaptive systems. I assume you're dealing with, and it changes in different contexts. So how do you work with folks who can be both over-controlled and under-controlled?
They would just, they will lean a little, even if they lean a little bit more in one way or another, we will put them then in our, like some people might not lean severely to one end. Some might be almost close to 50-50. But no one is 50-50 exactly. We will find out where kind of you lean and lean more or less. And then they might benefit from both standard DBT and RO.
Which we've seen a lot of,
Yeah.
a lot of the, or some of the research too, was RO-DBT done after DBT
Standard
skills,
DBT, yeah.
standard
Mhm.
DBT. So we might have people kind of go through standard DBT and then do RO-DBT after that.
Excellent. And then trauma, which may lead to one or the other. Do you specifically work with that, or you just do it more in the context of what you're talking about?
If someone has a trauma, you mean, and
Well,
or
someone has PTSD,
Mhm.
specifically the disorder, and that
Yeah.
comes up. Is there a way you shift and you're radically open?
what we've done is refer them to like an EMDR therapist at the
And that
same
can work in
simultaneously, or
conjunction.
working in conjunction or before or after. Yeah,
Excellent.
yeah. Other questions or observations or anything for Rose or I?
Any song requests?
In the classes, you're supposed to have technically one over-controlled and one under-controlled therapist.
Take a guess.
Thank you.
Thank you very much.
Thanks so much.